We have three exciting speakers to speak to us today about their experiences. Dr. Teresa Chan, Dr. Fahad Razak, and Dr. Venkatesh Thiruganasambandamoorthy. And I think we'll do the same format as we did for the earlier sessions. I'll introduce each one of them, have them come up and speak, and then maybe at the end we'll invite you to come up and we'll just do a bit of a question thing. Awesome, thank you. So the topic is knowledge translation. So I'm pleased to introduce our first speaker, Dr. Teresa Chan. Dr. Chan is the founding dean of the Toronto Metropolitan University School of Medicine, as well as TMU's Vice President of Medical Affairs. Previously, she served at McMaster University as Associate Dean of Continuing Professional Development and was an Associate Professor in Emergency Medicine under the Department of Medicine, the Faculty of Health Sciences. She was also a clinician scientist with McMaster Education, Research, Innovation, and Theory. In addition, Dr. Chan has been a practicing emergency physician with Hamilton Health Sciences since 2013. Notably, she was a PSI Graham-Farquharson Knowledge Translation Fellowship recipient in 2018. Dr. Chan has led more than 50 unique research teams while authoring over 200 peer-reviewed publications. She received in-depth exposure to social justice and advocacy while completing her Bachelor's of Education at the Ontario Institute for Studies in Education, and has brought that lens to her role as a physician and educator. Her clinical work focuses on helping patients navigate societal and systemic problems, preventing them from being seen as a whole person, and facilitating their access to care that maintains their dignity. Please welcome Dr. Chan.
Hello, everyone. Good afternoon, and thank you for staying. All right, I have some conflicts of interest. Moving on to learning objectives, I'm going to talk to you about these things. I don't have that much time, so I'm going to speed through it. All right, this is a land acknowledgement that our School of Medicine is bringing to the land of Brampton, which actually has a lot of the same history. So I'll ask you to take a moment and read through it and do your own reflection at some point about the lands where we're thankful to situate ourselves at this time, and to think about how we can give thanks to those who have come before us and respect what we can learn from them to take it forward in the future. All right, if you have questions and comments, I know that it's a different entity now, but you can reach me on X. I'm also on all the other social platforms, and LinkedIn is probably the most professional one, so you can search for me there. So I'm going to ask you to reflect in your head for a moment, what exactly is knowledge translation? I think there's different ways that you can do knowledge translation, and as an education scientist, I think it's the other side of really taking what new knowledge you've generated and educating people about it. So I'm going to bring some new conceptual frameworks in that hopefully kind of help you rethink the way you might think about knowledge translation as a scientist, the way that I think about it as an educator. Because education, at the end of the day, just like knowledge translation, is an applied science. But so are marketing and leadership. These are all applied psychological, sociological, anthropological sciences that really take, us as humans and think about how do we change hearts and minds. And let's be honest, out of these three applied sciences, the marketing people definitely do this better than probably all the other groups. But I think that at the end of the day, the basic psychology, the basic science of really how we think, the sociology of how we relate to each other, the anthropology of how we got to where we are, the history, all of those sciences that come before inform all of how we do these three jobs, but KT is probably a little bit of all three of them. And so I would urge you to start thinking about, well, if you're having trouble reaching people, stop reading the KT literature only. Hit a marketing journal. You never know what might be interesting to you and how you might be able to change it. And we already heard earlier, there's some very junior scholars who are very good at TikToking their way to knowledge translation. And I do think that if you looked at the trends of what makes the world go round, as in politics, for instance, what are the campaigns using? Like, how is Kamala Wins, Twitter account actually being successful at what they do, right? There's a science to the way that people relate to on these platforms, and I think we can learn it. And so my question to you really is, when it comes to translating theory into practice, what should we do in medical education? So, because I'm an education scientist, like there's many of us in Toronto. You have the Wilson Center in McMaster, they have Merit, TMU, we don't know what we are yet, but we're working with all these groups around us, and they're creating lots of good papers that can inform what we're doing at, let's say, a new medical school. And yet, how do we take that theory and turn it into real manifest reality? That's the challenge of knowledge translation. So I'm going to tell you 3 stories of how I've done this in my own practice as an education scientist, walking all the way from, I guess, bench to books, I guess. I don't know, classroom maybe. But the idea would be, how do we actually think through knowledge translation as an education scientist? The first story is, and I'm just going to harness the power of the work that Sharon Strauss did with some of her colleagues around that KTA knowledge to action cycle, right? We've seen this, we love it. We talk about this in our grants all the time. But I do think that when we have a cycle like that, it's good to think through, well, how do you actually do it, right? So one of the areas I've worked on is learning analytics, where we think about, in the age of increased assessment, let's say, in competence-based medical education, that's a thing. If you don't know what that is, I think you should be thankful, based on what everybody says. However, I would say that it's brought in an era where we now actually have data about our learners in a way that we didn't have before, right? We had, I had 12 report cards a year, so 60 by the time, and they probably missed a couple because in PGY5 no one filled them out, of my progress during my residency programs. And so the idea would be like, how do they actually know how I was doing? Now, most shifts, if I have a trainee, they get at least 1 rating from me, if not several. And so now we have thousands of data points on our trainees, and that ushered in a new kind of way of thinking about the analytic capability that we have. And so, yeah, I was a little bit of a nerd, and starting in residency, I started writing papers and publishing on some projects and using my residency fellowship time to actually create a data-driven, competency-based framework before CBME was cool and then not cool, and now we've got a whole kind of like series of papers that really says, okay, this is how you could do it without making people cry, and yet that probably wasn't enough, because I would go to conferences and, oh my gosh, this was if this was a meta conference, this would be a really considered really rock star kind of like room, because medical education conferences are very small. They're not like the AHA, where some of you may have presented, where there's like thousands of people. There's usually like 50 if you're lucky, and probably less than that, sometimes 5. And so conferences was not probably a great way to get the word out. So instead, what we did was we were like, okay, well, is there a way that we could put all of our learning together at the end of a program of research and write another paper? Because, we're still using the old way of thinking. And so we wrote a really nice translational paper about learning analytics and how we might use it. We used all the education sciencey things, such as we had a vignette to anchor people, and we made sure that all of the science was integrated, and we discussed the vignette and made sure we made it real for people. We had infographics, we had a table that made it real and really dissected out the case. So really turning this more into a case report kind of thing. And it wasn't really well read until we did a podcast about it. The journal invited us to do a podcast about this paper, and then the reads just took off. And it's because it's a newer journal, they were able to in real time report how many reads this paper was getting, right? And after the podcast dropped, it was 200 reads within a week. And then my ResearchGate also gave me some analytics. So clearly that was helping fill that void of really translating that knowledge and really connecting the people who needed to read this paper and the literature that's behind it to the audience. And so that's not enough either, though, because I think it's one thing to be a research scientist, but as an education scientist, what I was really being paid for was to implement CBME, right? And so the lessons we learned from our research, we also tried to make sure that we were doing this locally and implementing it into apps and renovating things and developing things into reality. And so that's a big part of my take home, is that KT and education are kind of flip sides of the same ways, and they can take in many different kind of forms. Sometimes there's a culminating paper after a program research that's more readable, more friendly, more digestible, and it's a little bit more friendly to the end user, right? Sometimes it's going to be a podcast so that you can tell people what you've done so they can situate it and understand what's going on, because, some people have long commutes and they like to have you in their earbuds and they learn from it. And then the last part is you have to actually bring it home. It has to be relevant to the people who have surrounded and taken shifts from you and carried you while you needed to go and present something or do something or, work on a paper. Sharing it with your local group to improve what they're doing locally and making sure that they weren't crying when we implemented CPME was really important. And so that was something that we did locally. So these are 3 ways in that first story that I was able to do knowledge translation. Okay, so what I'm saying is that you need to make the jump between the triangle to the outer circle of the KTA framework. All right, story number 2 is that I, at some point, did a master's thesis in health professions education, and I realized I was going from seeing one patient at a time to seeing many patients at a time. As an emergency physician, that's what you do. You kind of like in med school, you learn how to take care of one patient at a time, and then you get to reality, and you're like, oh, I have to bounce between 3 or 4 or 5 or 6 patients. In my last clinical shift, I saw 31 patients. That was not something I could have comprehended to do when I was a trainee. But I got there somehow. And so I built a tracker board simulation and yada, 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 did my thesis, developed a conceptual framework, and then I published this paper and found out, oh, hey, we have barriers to learning this skill, and there's definitely a need. And then I looked at the KTA framework and I said, hey, but how are we going to teach this? Because I could tell people conceptual frameworks and theories, and then I was practicing my defense with my friend Matt, and he was like, well, what are you going to do next? What's next? And I said, that's the name of my thesis. It's true. You don't have to read it to me. I'm going to defend it in a couple of days. And he was like, no. After you're done your thesis, it sounds like you've got this. I believe in you. He gave me the pep talk. I was like, I don't know. And then we started talking, and I was like, do you want to come over and play a new board game I bought? And he was like, board game. And I was like, you're right. Maybe could we make a board game out of the emergency department and actually close the gap there? And by the time I walked home, this isn't the first prototype. I think I found the photo in our text messages a little while ago. I should have put that in instead. But I couldn't stop thinking about it. And then I just I sketched out, this is what it could look like. And it kind of looked like this. Doesn't look like that anymore. But I realized that we could use a serious game, which is like a tabletop exercise. Many of you might have done these at the hospital to prepare for disasters. The city does them all the time to prepare for natural disasters or man-made disasters. And you could actually, use that platform to keep preparing for every day in multi-patient environments. And so I went on to develop Gridlocked. And the way that we did that was we actually went back to an education framework that was proposed by Kern in 1998 and his colleagues. And we thought, okay, well, we've done the needs assessment and we know what people need. Now we just need some goals and objectives and some really cool educational strategies. And really, it's nerdy cool, but it's still cool. And a board game is definitely cooler than a lecture, right? If you guys were all playing games right now, like the Kahoot you had earlier, that's a lot more fun than listening to me. So we went through, and this was the best lit review I ever did, because we had to play a bunch of board games and look at the mechanics. We did also review actual papers and there's lots of actual scientific literature and research on board games themselves. Then we actually had to design gameplay, and then we actually PDSA'd our way to success. So we did plan, do, study, act, and we kept on making it better. The best part was I got to interact with some trainees. And Paula actually is now, she's second year into her faculty role, so this is a long time ago. But Daniel, who's on the right, or on the left there, he came to me and said, I want to help you with the project. And I pitched him a bunch of different projects. But when I landed on, I want to make a board game at the emergency department, his eyes just lit up. And I was like, I think I got him. And so he came back a couple days later and said, can I bring my friends, Josh and Paula? Paula's a paramedic. I'm like, say no more. It's a board game project. You're going to have friends to play with, so let's do this. And this is them. This is the lobby of McMaster Children's Hospital, and this is them showing me a prototype because we needed somewhere that stayed open late. They have a 24-hour cafe, so we met up with one of the emerge docs that also helped with this, and they got some feedback, and we were prototyping. And more than 50 cycles later, We actually have a commercially available product, and we don't make any money from it because we donate it back to McMaster. But the idea would be that it's actually a game that you can actually buy, and people have bought it from all over the world. We've sold over 500 copies, and there are 7-year-olds that can manage department flow better than some PGY3s. Mainly because our PGY3s go off service and they do ICU and forget how to see many patients at once, and they focus really hard on the one resuscitation. So it's very interesting. We played it actually at a high school engagement event, and after 4 turns of this game, if I recorded the audio and played it to a bunch of emerge docs, they'd be like, I was like, what year residency are these people in? They'd be like, PGY 3 or 2. And I would be like, no, they're in grade 11. And it was pretty amazing. And the best part is when you actually talk to the people who played the game and you say, look, before the game, they probably didn't know anything to expect. But I'm like, okay, so if you're in the green zone and you can't see a doctor or nurse in sight, what do you think is going on? What's your mental model of what's going on? And all the grade 11 students, 16 and 17-year-old, they all rolled their eyes at me and said, obviously, Dr. Chan, there's red cards that are being taken care of down the hall. Like, they knew that there was someone being resuscitated, and that's why no one's here helping me with my stub toe or my laceration. And the amount of awareness that even 4 turns of gameplay we're able to unlock is huge. And so we're looking at how we can use this going forward as another research platform. So it's interesting, right? The knowledge translation product turns into something that can actually generate more research. And it did. And we're about 10 papers in to this whole agenda based on serious games. And in fact, we've inspired a whole serious game incubator program where we just help each other be nerdy about serious games, and we write workshops and grants and do things together and write papers. And that group finally got their first academic medicine scoping review accepted in the last couple of weeks. And so we're really excited for them because they were like going from nothing to like, we want to write about games, to like actually hitting one of the top journals on really their first go, which is impressive. And so take home point is number 2 is that I think you have to match your strategy to your audience. And so if you're trying to reach 16-year-olds, then a game probably makes more sense than anything else, right? Because lecturing them, they're just going to, it's Charlie Brown's teacher. Like, it's not going to happen. But they can actually engage with it if they can understand it, conceptualize it. Like, honestly, the 7-year-olds that like could actually probably tell our PGY2s how they're being inefficient because they actually understand the framework in their head. It's pretty amazing when you match those things. And I think the buy-in and the credibility come from you actually then thinking about how to be scholarly about this product in return. All right, story number 3 is the gap that's naturally there. And someone talked about this earlier, so I'm not going to bore you with too many details. But the idea would be that I think there's always been a gap between the triangle and the circle. And to fill it, I found that this Pathman's pipeline might be the solution, which is that there's lots of ways that you can lose data along the way, and that maybe you need to increase awareness and acceptance. And social media can be both used for bad and good. And I think that many of us scientists shy away from being out there because the bad is so sometimes unbearable, and the trolls are real, and someone called them keyboard warriors the other day. I'm like, that's a very interesting term. But sometimes you can have trouble with others when you're out in the public. But I think some of us have to earn the thick skin and learn how to do it. Because it's not Web 1.0 anymore, where it's really hard to provide, like Ariana Huffington, it took a whole bunch of people to actually get a website up. But now, you can have your podcast later today if you wanted to. So it's just so easy now to get out there. It's not necessarily Facebook anymore. It's probably like TikTok now. But, it's one of those things where in the sea of isolation where we're not really able to engage with each other, especially emerge docs, we're like working at night and our friends are all like asleep or, vice versa. Sometimes you can need a community of practice somewhere, and that's what Twitter was for me for a long time. It's turned into X now, but it could be LinkedIn, it could be Instagram, it could be TikTok. And in emergency medicine and critical care, we've created something called Free Open Access Medical Education, where we share some of this stuff through blogs, podcasts. Many people do education work. This was the bulk of my KT fellowship, was to study this group and really understand why there were millions of views a year for some of these blogs. And what we realized is that there's a lot of kind-hearted people who were educating for free for big publisher companies anyway, and they were just tired of that, so that why don't we just start our own why do we have to give all of our volunteer work to Elsevier? And I'm like, good point. And so it's very interesting to watch this group evolve, and for them to take some of the principles from marketing and import them in to make learning sticky. And so I call it kind of learner-centered education 2.0, or hiding the kale in the smoothie. Because when you've got a blog post about beta HCG discriminatory zones, which is like not that exciting, maybe for Andrea because she's a radiologist, I don't know, maybe. But, you know, putting it on our Facebook and getting engagement in the thousands, right? I mean, I'm grateful all of you are here, but the reach for this blog post is much higher, right? And so how do we do that? We also looked at using some of the same techniques that many marketing specialists were doing in making infographics. The infographics to the left, we did them because Laurie Morrison, who's one of our researchers here in town in Toronto, she reached out and said, hey, we're about to drop to 2015 guidelines, sorry. Do you want an advanced copy as a press outlet? I'm like, sure, where can I send the NDA? And so we got about 5 days notice ahead. And I sat down next to a med student who was really keen, volunteering for a conference. I'm like, I have this dream of us doing like infographics about the AHA guidelines for the updates, but I don't really have time. He's like, I got time. Little did I know he was actually running a party that night at his house, but he kind of abandoned all of his friends to make the infographic template. And then we populated it over a couple of days, and lo and behold, these 2015 infographics took off like wildfire. They were posted everywhere. People were sending me tweets from all over the world, like South Africa, Hong Kong. Like, it was amazing. And then the AHA, the next time around, like, can we partner with you ahead of time and give you a sneak peek like 3 months in advance? And then can we host them on our website? I'm like, yes, you can. And so they actually paid Alvin the next time to work on that project. And since then, we've actually partnered as Canadian with other groups to be their knowledge translation specialists when they do CIHR grants, like the CERN group that arose during COVID for emergency care. They actually did some of that work, and the PCARN group actually commissioned us to do some of that infographic work as well to translate, because they were having trouble getting people to adopt their head rule, which is when not to CT a kid's head. And there's people that have been doing the science around this, with like Dr. Ibrahim at Michigan. And I think the idea would be that harnessing some of the marketing techniques, like creating a platform and a home base for your research. This is one of my research groups. And we've done our study engagement through here. We've recruited through this website. We've posted papers afterwards. We get to tell our story in the sequence that we actually did the research rather than the dates in which they were published, because some journals are faster than others. And so it makes a lot more sense to do it this way so that you can actually see how the program of research evolved. And you can start a website in the time that I started talking. Someone could have built a website by now if they really wanted to. And then you have to think about some embassies, so not just having a platform, but places where you can put stuff. One embassy that we don't use enough is Apple actually lets you publish ebooks for free if you give them out for free. So you can put a Creative Commons license out there and get people to work on some of your work, right? So Jennifer Tay, I was thinking it'd be great if you had options for some of your toolkits to get it out like that, right? There's also ResearchGate and Google Scholar. Those are other outlets. If you're not there, people might not be able to discover your stuff. And then for the educators, you can always, if you've got a workshop or some resources that you want people to use, there's Method Portal. And then I think you should probably pay attention using altmetrics and other things to see what people are saying about your research. And you can like go through pages like this where you are on the journal, and then you can click into it and you can find out where people are talking about your work, and then you can actually click and see what they're saying, which is nice. So take on point number 3 is that you have to understand your audience, what's popular, what do they use, and go to those media, but also find a way to get it beyond the usual suspects, right? So if you're just going to conferences, you're just publishing papers, you're not going to get the same reach that you have otherwise. All right, so that's basically it. Thank you so much.
Thank you. So I think I was excited to get started. I'm not sure I introduced myself. So my name is Andrea Gershon. I'm a respirologist here at University of Toronto, but also a director for PSI Foundation. But not about me. Let me tell you about our second presenter. Our second presenter, Dr. Fahad Razak, is a Canadian Research Chair in Data-Informed Healthcare Improvements at the University of Toronto and an internist at St. Michael's Hospital under Unity Health Toronto. He co-founded Gemini, which is the largest hospital research network in Canada and one of few such examples globally. He was previously the scientific director of the Ontario COVID-19 Science Advisory Table and co-authored more than 50 science and policy briefs that shaped the policy, public health, and clinical response to the COVID-19 crisis. He is also the provincial clinical lead for Ontario Health and a senior fellow at Massey College. Dr. Razak completed a degree in engineering science and a medical doctorate at the University of Toronto. He was the first physician appointed as the David E. Bell Fellow at Harvard University. Notable recognitions include the President's Impact Award from the University of Toronto, the Graham Farquharson Knowledge Translation Fellowship from the PSI Foundation, and the Canadian Society for Internal Medicine New Investigator Award. He has received over $65 million in grant funding as principal investigator, has published more than 100 peer-reviewed publications, and is on the advisory board of the British Medical Journal. He is active in science communication and co-founded The Rounds Table, a free podcast about new research in medicine that has been downloaded over 400,000 times in 150 countries. He has written extensively for news sources such as the Globe and Mail, the Toronto Star, and Maclean's. Dr. Razak has been primary supervisor for research projects for more than 40 trainees, resulting in 50 peer-reviewed publications with trainees as co-author. He received the Teaching Award for Excellence and the Dr. Robert Sargent Award for Mentorship at the University of Toronto. Please welcome Dr. Razak.
Thanks for the kind introduction. It's a real pleasure to be here. I was a very fortunate recipient of one of the KT fellowships from the PSI, and actually I'm going to close my presentation. I'm going to put my timer on as well to make sure I stay on time here. I'm going to close my presentation actually by sharing some of that work and showing you how we've taken it out into hospitals. I'm going to talk about our experience building the Gemini platform, which is, as Andrea mentioned, the largest hospital data sharing network. And because it's really been very pragmatically built around using existing clinical data, I would argue that it's well set for KT because it's drawing on the very data that we're using for clinical care. It's trying to understand that and then use that information to deliver insights back into the clinical environment. I'm going to give you some examples as well of what we didn't anticipate when we created Gemini, which is how effective it is to harness clinical data from the health system when there is a crisis. And the crisis that we pivoted towards was COVID. But I would argue that this kind of infrastructure is valuable for Canada for wildfires or flooding or any unknown pressure that's going to arise. Often creating bespoke studies is something that takes a lot of time. You have to write grants, you have to get funding, but harnessing health system data and as close to real time as possible, and that's where we're going with our platform, is really critical to respond to those unknown threats. I'm a salaried employee of Ontario Health and from the Canada Research Chairs program. So data analytics has transformed many industries and sectors, but has, I would argue, largely not been used to nearly what its potential could be within health. And one of the reasons is that data is fragmented. It's incredibly fragmented, and it's siloed, and it's not standardized. And the investment to deal with that problem in healthcare has been very limited, as all of you know, and it's been a real barrier. And I would say if you look on the left at the financial industry, much of their investment has been addressing that interoperability question, access, governance. Whereas in healthcare, you have siloed institutions. These could be primary care clinics. In our example, it's hospitals, where there's these barriers that have been hard to address. And the work of our team, and we have more than 40 full-time people over the last decade, has been trying to address that very problem, which is how to get through that silo and bring hospital data together. So we've now built the largest platform in the country, and I just want to give you an example of where the data comes from that's really critical for what is possible now because of how much digitization has happened in healthcare. This is a case example. I'm not going to read through it, but this is someone admitted with hemorrhagic bleed, admitted to the ICU, receives transfusion, receives a procedure, is discharged, is then readmitted. And if you look at the data that's captured in this case vignette, we've color-coded here all of the data that's captured in various digital repository somewhere in the system. And the question is, how do you get to that data? How is it well governed? How do you work with interoperability? And how do you pull that all into one place so you can gain insight on the patient and the outcomes and the care quality that was delivered? What we started with, and this slide is not showing up very well, but what we started with was the administrative data backbone from CIHI, which is mandated by legislation for Canada, which is what has to be generated for every case that's admitted to hospital. So that is name, sex, age, the reason they were admitted, comorbidity, very limited administrative data. And what we've really focused on, and again, I apologize for the formatting not working well here, is we've focused on these other data fields, which are everything from the clinical notes that we generate as clinicians, the vital signs, the lab tests, the medications, the imaging reports, all of that information is in there, and the work really is to try and get that out. We've worked a lot on quality, so when you are using this kind of information to drive quality of care at the bedside, telling a physician or another clinician to practice differently because of these reports or analytics that you're generating, if you're using it to drive research grants, you need to ensure that the data is high quality. And again, it's a real morass behind the scenes, behind the front end that we see in the electronic health record. Behind that is a very chaotic system of connections between these data repositories. And so a lot of our work has been trying to figure out how to get that data out in high quality. And we've gone through this iterative process. And again, for formatting, you're not seeing this well, but what I've also highlighted is a lot of the papers that we've published from this have very direct trainee involvement. And so this may show up in another slide, but you'll see trainee names in purple pop up. And many of our papers, and Andrea mentioned, have had trainee involvement. Okay, so where are we at today? So we cover just over 35 hospitals, which means we have about 60% coverage of all of Ontario's medical beds. That includes every medical admission and an ICU admission, all of the data from triage right to discharge. We have that data stored in a high-performance computing environment, so we work through the governance of how to get people access, even if they're in Thunder Bay or Windsor, Ontario, where I'm from. How do you get access to this kind of data? Very sensitive information, a cancer diagnosis, an HIV test. How do you give people access to that in a responsible way? We now hold data on more than 2.5 million Ontarians and many billions of data points because it's incredibly deep information on every individual. It's created a large active user base, so we have more than 1,000 active users that range from researchers to clinicians. We have more than $80 million of grants that are supported. There's 15 CHR grants that are active that are running off of this data set right now. And it's importantly a system resource. So although we had to do the build originally at Unity Health, the majority of that research funding now is not held at Unity Health. It's held at other institutions across 13 institutions. I'm going to give 3 very brief examples about how this kind of data can be used. The first is an unexpected way, but I think important to recognize, which is response to a crisis. The second is to use it for quality improvement, for audit and feedback, and for delivery of information back to clinicians. We run the largest audit and feedback program in the country here in Ontario using this data. And the third is an AI example and a deployment example, and this is what I was very fortunate to receive the KT Fellowship from PSI. So starting with emergency response, these repositories, because they are the place where patients are presenting during that crisis, can be a source for rapid insights about the health system, about what patients are actually presenting with. And so we were able to quickly pivot our focus on our analytics as the pandemic rolled in to provide Canada's first estimate of what a COVID hospitalization looks like. We were able to publish this based on a study of roughly 1,000 COVID admissions. And we were able to also provide Canada's first estimate of where critical drug shortages were going to occur. So as many of you know, the first life-saving therapeutic for COVID was dexamethasone, more than 50 years old, pennies per day to prescribe, widely available. But the second drug that was found to be life-saving was tocilizumab, an IL-6 inhibitor, highly constrained, a single manufacturer globally. And we knew that there was going to be high demand for this drug, but how big was the demand going to be and how big was the shortage going to be? We were able to generate that estimate for Canada. We showed that supply was going to roughly hit about 5% of the people that came in, whereas the number of people who would be eligible would be closer to 50%. And so we showed that there was going to be an enormous gap, and that led to a triaging framework that we proposed in this paper. Well, I see the first trainee name has popped up. A triaging framework that we proposed in this paper, which was adopted in Ontario as the provincial triaging framework for this drug when we ran out of it. A third example is the impact on people with disabilities. So my mother has multiple sclerosis. She's been disabled my whole life. And so the impact of COVID, I think, was, for me, very dramatic as someone working on advisory, but also seeing the number of people with disability who ended up in hospital during this pandemic. And we knew that people with disability in general do worse once they're sick and in hospital. But the additional punishing strategy that was adopted in Ontario and in Canada for good reason was limiting visitors. And the limitation on visitors was because, of course, worrying about disease spread. But for someone with a severe disability, that visitor or that personal caregiver or that family member or advocate or friend is often a critical person in ensuring that they receive good care. It can be things that involve telling a nurse or a physician someone is in pain but they can't speak, help them. It could be the dignity of personal care, of toileting, of nutrition, but that caregiver is really important. And so the first thing we wanted to do was to look at whether patients with disability did disproportionately worse once they were admitted, even independent of severity of illness and other scores to quantify severity. And we showed, in fact, they did much worse once they were admitted to hospital. But the output from this then was some advocacy. We wrote op-eds in the Globe and Mail and the Toronto Star. We contacted the CEOs of hospitals, and it led to the reversal of visitor policies for patients with disability at a number of hospitals. The second example I want to go to is the use of this kind of data for audit and feedback. So audit and feedback is a broad term that's used to describe the process of taking clinical information, quantifying it, providing that back to a provider or a ward, and using that to drive hopefully positive change in clinical practice. There's been a Cochrane review done about audit and feedback. The estimate is that on average it results in about a 5% shift in a positive direction in terms of the way that clinical care is delivered. However, if it's driven by data and it's embedded in a community of practice, it could be closer to 15 to 20% change, which, as all of you know, in clinical practice, that's a very significant change. Even 5% is significant, but if you can get close to 15 to 20%, that's very significant in terms of improving care. When I started at St. Michael's a decade ago, there was no Gemini, and the idea for building Gemini actually came from our first quality of care retreat that I was now a member of as a staff physician, where I naively thought that physicians received some information about the quality of care that they provided. So I provide acute care on the medical wards. I thought that I would receive information about the number of my patients who died, who were readmitted, who had complications, simple information. But the truth is no physicians receive that information, as you know, systematically in hospital-based care. And so the creation of Gemini was actually that observation. We had friends and colleagues who were practicing at different hospitals, and we said, let's get together and try and see what we can do with information that's already generated and in the system. And that led to this audit and feedback program. And one of the things we first did is quantify how big the variation is, and we found that for general medical wards, depending on who you were admitted to, you could have, for example, a 60% longer length of stay without any other positive outcomes, like lower readmission rate, for example. We found that you were 80% more or less likely to receive a CT or an MRI scan at the physician level, depending on who you were admitted to. We presented this to the Deputy Minister here in Ontario, and that supported the creation of the General Medicine Quality Improvement Network. This is an example of the kind of variability we saw. This is an example of length of stay. Each individual colored bar here is a staff physician. Each large bucket, A, B, C, D, G, is one of the first hospitals in our network. You can see enormous variations in things like length of stay and imaging use and blood work use and readmission rates. So we presented this information to the Deputy Minister, and that led to the creation of the General Medicine Quality Improvement Network, which is the largest audit and feedback program in the country, and it's co-led by myself and Amal Verma at Unity Health, and it's an Ontario Health program. And the goal here is to take the analytic platform from Gemini and drive the information back to a frontline practicing physician and to the wards where that care is occurring. And this is a screen grab. These are highly interactive reports. So every physician in the network now, covering roughly 60% of the province, receives one of these detailed reports provided on an annual cycle. It gives them lots of mineable information about the care they're providing relative to their colleagues. Physicians then take this data and they have annual retreats with their colleagues at their hospital. They have their reports. They can identify quality improvement targets. They can then use the reports to track change over time. Importantly, we wanted this to align with other accreditation requirements. So you can use this, for example, to offload your CPSO quality accreditation requirements. So we wanted kind of system incentives to align. 2 years ago, we also, for the first time, started to provide reports for hospitals. And so now hospitals can see their performance statistics based on these Gemini analytics, allow them to compare against other peer hospitals. This is now used, for example, for the mandatory legislated quality plans that hospital executives have to submit to the ministry to say, we want to target our blood work use or our readmission rates. The point is, you can now provide data to say what your baseline rates are, pick a target, be intelligent about why you are choosing that target based on your performance, and then use that to track changes over time. I have a number of research examples. I'm not going to get into all of them. I'll just pick one example, which I think is an interesting illustration of what you can do when you're harnessing health system data. So this is a paper that we published just in the fall in CMAJ looking at antimicrobial prescribing on medical wards. And this was, interestingly, the first global study to look at prescribing of antimicrobials. We know that there's huge volumes used in hospital. We know it's highly variable. We know it's unstandardized, but how big is the variation? And what we found, and every dot here represents an individual staff physician, 1, 2, 3, 4 are 4 hospitals as an example. We found on metrics of prescribing, the top row is days of therapy, the second row is days that are free of prescribing, the third row is the intensity, so using a very broad spectrum or powerful antibiotic as opposed to a narrow antibiotic. We found enormous variability independent of the clinical severity of patients. And this represents the cognitive process that physicians go through. Some will accept lower risk, some will accept higher risk, and your prescribing is generally driven by that kind of risk perception. Now, importantly, the very high prescribers versus the very low prescribers, there is no improvement in clinical outcomes. So even if you are a high prescriber, you don't have lower length of stay, lower ICU admission rate, lower death rates, lower mortality rates. And so this highlighted an opportunity to really look at standardizing the way that care is being provided. And I'm delighted to say we proposed this model now where a randomized control trial can be run from start to finish using health system data. So highly pragmatic, accessing 60% of the province's data, measuring baseline prescribing using existing data, delivering a report back to physicians using existing data, looking at change over time using existing data, and looking at clinical outcomes for harm or benefit using that existing data. So the whole process can be run start to finish. And our estimate is that if this was traditionally done using a standard randomized control trial method where that work was done manually, this would cost about $5 to $6 million, which is not unreasonable across a province that is 15 million people where you're covering 60% of the province. But we're able to run this trial faster at under $1 million because we're harnessing that health system data. And that kind of pragmatic structure to run randomized trials is going to become increasingly important. We saw it during COVID. At one point, 80% of the entire evidence base for COVID therapeutics came from the United Kingdom for the globe's entire evidence base. And the reason for that was that harnessing in many ways of that existing data. And so this is the way the world is moving, and we think this is a good example of what can be done in Canada. I'll finish by giving the example of delirium, and as I said, I was very grateful to be funded by the PSI to do this work. We focus on delirium because it is the single most important cause of hospital-acquired harm now in Canada. So roughly 20 to 30% of all patients admitted to an adult medical ward will become delirious. It is a combination of underlying risk from age, comorbidity, and the severity of the illness. But importantly, a hospital is a very deliriumogenic environment. It's noisy, people don't sleep well, their nutrition is poor, they're receiving a lot of medications which alter cognition. This is a huge problem, and once it occurs, it has catastrophic effects for the individual patient, for their family, and for the health system. So on average, 8 days longer length of stay, double the mortality, 2.5 times as likely to end up in long-term care, permanent cognitive deficits for many patients, and about $11,000 per patient increased cost of care. It affects about 500,000 people per year in Canada. Now, delirium, despite its importance and despite it being the only cause of hospital-acquired harm that is consistently rising over the last decade, is very poorly measured. So if you use a gold standard to look at delirium rates, and then you look at the ICD-10 code, the ICD-10 code only has a sensitivity of 25%. So in other words, roughly 70 to 80% of all cases of delirium are missed by the best existing health system data. If you have an indicator like an ICD-10 code that is that poor, it is very difficult to act on this problem. And so the question that we asked and what we proposed to PSI in the grant application was, can we use artificial intelligence? You've heard a lot about the promise of artificial intelligence. I'll say I work closely with Mohammed, who was here this morning. There's very few examples where it's actually embedded in clinical care yet. So we asked, what could we realistically do in the system as these EHRs currently exist? And we said, we could probably improve identification. That's not real-time prediction. It's going to work as well in Windsor as it's going to work in Thunder Bay. But identification of a problem where you're missing 70 to 80% of all cases would be a useful application of AI, and it doesn't have to be real-time. So we've been able to develop an AI algorithm that's now improved accuracy of recognition to 90%, and it runs purely on that existing data. No additional manual work required. And this is now Canada's largest multi-hospital AI rollout, where this indicator now is being rolled out across 10 partner hospitals, and it's going to allow executives and wards to identify where those delirium rates are occurring with high fidelity, and then target resources, because we know that a multi-component toolkit that is easy but very labor intensive, increased mobilization, increased nutrition, enhancing the sleep environment, it can be done, but we don't have enough nurses. We don't have enough personal caregivers. We don't have enough physicians. So you need to know where to target that. The estimates based on randomized trial evidence is that can reduce delirium rates by about 40 to 50% if targeted. So the goal here now is to roll out this indicator and allow that targeting of delirium resources, delirium prevention resources to occur, hopefully to reduce delirium rates over time. I'll close by saying electronic health records and clinical data is an enormous opportunity to use data that's generated as part of routine clinical care efficiently, scalably, and I think with wide pragmatic implications for the way we do research. Canada is behind in the use of this kind of data. The European Union has invested $1.2 billion to harness this data. The United States has invested over $1 billion. The United Kingdom has invested over $600 million. Canada, as of yet, has made no systematic investment in the use of this data. There's a lot of opportunities, and the world is changing quickly. So where are we going? We were fortunate to receive a $5 million investment from the Ministry of Health this spring to expand Gemini to pediatrics. And so by early 2025, we'll have 80% coverage of all pediatric beds in the province, and will allow a lot of opportunities for pediatric-focused care. We're starting an AI rollout to see what is actually possible in the health system. We're looking at a large-scale pragmatic trial using health system data, and we have a proposal before the federal government to expand on this clinical data model to bring in Alberta and Quebec and Ontario into one common framework and to move that lag closer to real time. So I'll stop there.
Our final presenter, Dr. Venkatesh Thiruganasambandamoorthy, is a professor in the Departments of Emergency Medicine and Epidemiology at the University of Ottawa, as well as a senior scientist at the Ottawa Hospital Research Institute. He completed his master's in epidemiology in addition to his research fellowship, and mentors master's and postdoctoral students. He has established one of the largest programs on ED syncope and pre-syncope. Dr. Venk is internationally recognized for his research on syncope and is a recipient of several peer-reviewed grants from the Canadian Institute of Health Research, Heart and Stroke Foundation of Canada, and National Institute of Health. He has won several excellence awards, including the National New Investigator Award from the Heart and Stroke Foundation, Canadian Institute of Health Research Mid-Career Lecturer Award, the PSI 50th Mid-Career Clinician Award, Tier 1 Research Chair Award from the University of Ottawa, and is a current PSI Mid-Career Knowledge Translational Fellowship recipient. Dr. Venk works with the Venk Group, whose goal and strategic vision is to improve the care of people with cardiovascular emergencies, specifically syncope, pre-syncope, and chest pain, by reducing morbidity and mortality using robust risk stratification. He works to improve the safety and efficiency of ED management for patients with possible acute coronary syndrome. The implications of the Venk Group's research includes reduction in healthcare costs through standardization of care and potential out-of-hospital live cardiac monitoring of at-risk patients. Please welcome Dr. Vink.
Thank you so much, and I am the person who's standing behind you and you reaching home. Let's have it quick. So I'm going to talk about how to translate evidence to practice. Two important aspects of it. How can you plan for it, prepare for it, and how are you going to evaluate the knowledge translation? What we are going to do is that we are going to talk about some of the preliminary work that needs to happen before you undertake knowledge translation. And once you're ready for knowledge translation, what is the methodology that you're going to use, plan for the knowledge translation, and as well as the most important aspect of process evaluation. You have to evaluate your knowledge translation through specific processes and specific measures. Thank you for the kind introduction. And as you mentioned, I got grant funds from most of the peer-reviewed sources, and I don't have any conflicts. We are going to take the example of our Canadian ED syncope research program to highlight the preparation and the implementation and evaluation of the implementation. So it's possible that the evidence is already out there for you to do the knowledge translation, or you might have to create the evidence. In our case, we created the evidence, so we were a little bit delayed. But I'm very happy that we created the evidence, because I still remember the Canadian EM at some point in time said that probably the Israel-Palestine conflict will be done, but the solution for syncope will not be there. But I proved them wrong. So after you have the evidence, it has to be adapted to your local context in the form of some sort of recommendations that works for your context. It can be a local institution, it can be a local region, it can be a countrywide recommendation. And then you have to look for barriers and facilitators for implementing those recommendations. You have to develop knowledge translation strategies. Then you will do a pilot implementation to see if it will work. And finally, you do a multi-center implementation, and then you go on for dissemination. So, back in 2010, when I had a lot of trouble, I was working not too far from here in Lindsay, Ontario, and I was single, and I used to work all the weekends. So it was a retirement community, and I used to get a lot of people from church having fainted. But they have multiple comorbidities. They were on blood thinners, they were at risk for pulmonary embolism. So there was this huge need for me to just figure out what was happening with these patients, what is the risk of these patients dying or having a serious underlying condition that caused the syncope. So I did not find any solutions. I looked for textbooks. So then I went they came to University of Toronto to do a 5-week research program, only to create some paper guidelines where I used to have a small little book where I used UTI, this is what I do. And for syncope, I don't know what to do. So I needed that piece of paper to help me to find a solution. And after 5 weeks of work in form of literature search, I did not find anything. I ended up in Ottawa doing a research fellowship and did a retrospective study. And thanks to PSI for funding our first prospective study, which just started our program. And we started a prospective program in two hospitals in Ottawa, extended on with CHR funding to 4 more hospitals, developed the Canadian syncope risk score after recruiting 4,000 patients. Then we recruited another 4,000 patients and validated the score in 9 Canadian EDs. We put together a few more aspects of it that I'm not going to talk about, a lot of evidence regarding management of these patients, but an important aspect that we got was that who are all the people who are going to benefit with the hospitalization. We were able to do propensity score analysis and then figure out that patients who are truly higher risk as per the scoring system are going to benefit from hospitalization than the rest of the people. And then finally, we developed a calculator. You as an emerge physician or anybody who is looking at a patient who has fainted and who is presenting before you, using this calculator, you should be able to tell what might happen to the patient in the next 30 days. Overall, what bad thing is going to happen, and specifically what bad things are going to happen. So this is the scoring system. I'm not going to bore you, just go through the variables, add the total score, and then it'll give you overall risk. But more importantly, after collecting 8,000 patient data, we were able to figure out how many patients are going to die, how many patients are going to have an unexplained death, such as just like they're going to be dropping dead for no reason at home. And then how many patients are going to have arrhythmia outcomes, how many patients are going to have non-arrhythmia outcomes such as pulmonary embolism, bleeding, sepsis, things like that. So for example, if you are very low risk, your chance of anything bad happening in the next 30 days is 0.3%. So if you're low, it is 1%, and it increases all the way to 42.7%. And overall in the population, you have an average of about like 3.6% of patients having some sort of bad outcome after they are discharged from the emergency department. When we had this, now we know the number who is going to have a bad outcome. What do we do with this number? So that's when preparing for the knowledge translation happens. So we use the results from our studies. We have KTA experts and health administrators. We conducted semi-structured interviews of physicians, which included all the stakeholders who are involved in syncope care, and as well as patients. We interviewed patients, what do they think about these type of outcomes happening, and we came up with the practice recommendations, which look like this. If you are low risk, discharge home, and if you have a problem, see your physician. If you are medium risk, you are a small risk of having something like an abnormal rhythm, you can have a monitor and go home. If you are at higher risk, you might benefit from a hospitalization. So the proportion of patients who are higher risk is about 5%. Even we are the lowest hospitalization rates in the entire world, which is about 12%. Even for us, it will have a reduction in hospitalization to about like 5%. So this was the recommendation. And we went through these barriers and facilitators of these recommendations. What will happen if we were to apply these recommendations? And we asked all of these physicians and patients. So I will just only highlight a few. For example, we need proper continuity of care. Like if you're just saying follow up with somebody if there is anything bad happening, or if you're going to monitor these patients, who's going to get the monitor, and if there is anything bad happens, such as like very fast heart rates, very low heart rates, who's going to contact them? Are they having a bleeding? Are they developing a sepsis? Something needs to happen. So that was considered some of the barriers. They thought that the workflow will be easier once we have a standardized workup using Canadian Syncope Risk Score, but at the same time, some people also thought it might be difficult to use it. It might have an impact in ED times with respect to flows. Some thought that this standardized approach will provide more time for us to talk to the patient about their risk and have a patient-centered discussion about making decisions about their disposition. And then during the later in the process, when we developed the KT strategies and the educational materials, some of the physicians thought that was great with respect to all the educational materials that were introduced. It will be very easy for them to talk to them. And from the patient level, it was the low-risk patients who were very worried, but when they had the infographic, they were totally happy that their chance of dying is like 0% within 30 days. That was what made the difference. Their major thing is, I fainted, which is equivalent to dying transiently. Is it going to happen like a permanent one? When they knew that it was not going to happen, that was the biggest relief for them. And those infographics were extremely useful for them. So those were the facilitators. Then what we did was, we did 3 online workshops to create user-centered design workshops to create our KT strategies. The first one, we had identified all of these facilitators and barriers, and then we developed some strategies. So we asked them, what type of strategies would you like? They talked about they're wanting posters, they're wanting videos about how to use this, infographics, particularly to discuss with the patient, which will be useful. They wanted presentations. Most importantly, they wanted the integration of the tool into their day-to-day activity of working in the electronic health records so that it is easy to access and it's just there. And some kind of pop-up to remind them that it is there and available. And they also wanted non-ED physicians such as cardiologists and internists to know if they are discharging the patient that it was based on evidence, and if they're asking for a consultation, it was also based on evidence. So they also audit and feedback. The next step what we did was we developed all of these things and then asked them, is there any other strategies that we are missing? And what do you think of these materials? And finally, when we fine-tuned all of the presentation in a user-centered design, we talked to them about any other strategies that are missing and finalize these materials. I'm going to show some materials that we developed for KT. This is, for example, a pathway that we developed, which just tells them when to use, when not to use blood tests, how to calculate it, and what to do once you got the final score. And we also had QR codes as to how to just use this form, and as well as access to an online calculator. One of the things in the KT was about the abnormal QRS axis, minus 30. And even don't ask me now, is minus 29 less than minus 30 and minus 31 is less than minus 30? I don't know. So we developed an automated calculation of that, like where you can put positive, negative, a number, and then it says whether it's normal or abnormal. That's, for example, one of the things that gets confused with respect to physicians. We cannot calculate.
Hello, emergency department physicians.
This is an example
Control period
of a
of the
video
syncope
that
study
we
is
made
now complete.
about how to use
Thank
the
you so much for your
tool
support.
and things like that. I'm
We
not
are
going
now
to
in the
bore you with
intervention
entire
period
video.
where
It's
we
about
will be
5
using the
minutes long,
Canadian syncope
but this is there available right there for them to use
Canadian
it.
team.
And then we wanted to create a website where they can have all of the systems that are available, easy access to any of the materials, anything that they wanted. We tried to create within the hospital system, and finally within all of the hospitals trying to create that, it was a disaster. So we centralized it, put it, and my team created. I have no idea about all of this website creation. These younger generation people, oh my God, like, they are like crazy. They created this website, and they had a vision, mission, and they had a calculator for it, which gives you, and it tells you what the risk is, it tells you what the breakdown of the outcomes are, and then it tells you an infographic to discuss with the patient. Electronic health records integration. So we put in a link called a research link, but technically it is like kind of clinical aids. You click that link, and then it takes you to your calculator, you calculate it, you can copy and then bring the results back. And we also developed a pop-up system. If your final diagnosis or your presentation is syncope or pre-syncope, then there is an advisory that comes up into the best practice advisory for you to use the tool to just figure out what the risk of the patient is. And there is a scoring tools section within Epic. We also integrated into Epic, and we also integrated into Cerner, into the clinical decision tools section, which gives exactly the same thing. And then after we have all of this ready, how to integrate it, then we embarked on the pilot implementation trial, which we did it at 3 hospitals, which is basically the Ottawa Hospital and the Queensway-Carleton Hospital, but the Ottawa Hospital is the same cluster, same physicians working, so we had to combine both of the hospitals together. And then we did a non-randomized stepwise trial. In October 2021, the first cluster hospital switched over from control to intervention using all of these KT strategies, and the second hospital switched over in November. We recruited about 1,000 patients, and I'm going to talk to you about 3 words in KT: adoption. Over the course of time, of all the physicians who are working in the emergency department, what proportion is starting to adopt the tool? That's the top line. Reach. Every time a physician sees a patient, are they using the tool? Regardless of whether they are using it right or not, or if they are using the correct recommendation, are they just using it? That's the second line, which is reach. And then the fidelity is, are they following the recommendations overall? So low risk patients, they are following in 99 to 100% of the time. High risk patients, about 75% of the time, because like patients sometimes like don't want to get admitted. Like, listen, I know my risk. I'm like 100 years old. I'm going to go home. So in the middle, once again, the medium risk patients, it's primarily people don't want to wear these wearables for like long periods of time. They are not going to have a pacemaker, or if something bad were to happen, they are happy to be dead because of their age or because of their wishes. So overall, we found that the fidelity of these recommendations being followed is good 88%. Now we are embarking onto a multi-center trial. Overall, it is to just make sure what is the efficiency and safety of implementing this in 16 cluster hospitals, and what are the outcomes. Because we have to start in a control period and switch over to the intervention. All of the hospitals have to start in the control period. We were trying to get 16 cluster hospitals, 19 emergency departments across the country to go. We could not do it, so we had to divide them into 2 clusters, and we are almost finished the first cluster. We are switching over in November to the second cluster, and every 3 months, 2 cluster hospitals will switch over from control period where they don't have any intervention at all to having all of our intervention strategies. So all the patients will be enrolled. There will be a 30-day follow-up. There is an administrative linkage for 1-year outcomes, and ED physicians and non-ED physicians who are involved in care are the people who we are targeting these knowledge translation interventions. We are hoping to enroll about 11,000 patients to prove that we can reduce the hospitalizations by about 5%. More importantly, thanks to PSI, we are also doing the most important part of evaluating this process of implementation with an objective of, are these strategies addressing the barriers that we know about? And is our strategy a success or a failure for each of the strategies? So we are going to do surveys of physicians before the intervention is being implemented, and after the intervention is being implemented, we are going to ask about their knowledge, confidence, and what strategies worked and what did not work, and what would they like it to be improved. And we are also collecting data in the form of informal conversations, and there is a logbook. Every time anybody says anything, it is entered into the logbook in order to make sure that the knowledge translation in the future aspects will be like all be polished. And all of the concerns, one of the concerns, for example, when we did the pilot implementation was we did not tell the non-ED physicians, so there was a problem. So now it's a standard procedure that every time when it is implemented, we need to have the family medicine hospitalists, internal medicine, cardiology colleagues all on board to make sure that everybody knows about the implementation. And these implementation strategies were supposed to look at to counter all the barriers that we have previously identified. And the objective 2 of the process evaluation is to once again talk about the reach, adoption, and fidelity of all of the sites. And finally, we are going to conduct interviews of people who are low adopters, which is use less than 25% of the time their tool. 25 to 50% will be medium adopters, and more than 50% will be high adopters. We are conducting interviews of those physicians who are low, medium, and high adopters to figure out what is that went wrong, what is that went good, and so that we can just fine-tune our dissemination process. If there is going to be 24 participants, once again, did you use this Canadian syncope risk tool? What context? Were you engaged? How was the execution and progress of the implementation, and what worked well and what did not work well? Now, sorry, we are, as I said, towards the end of the first batch. The first batch will complete all enrollments by January 2025. We have enrolled about 4,000 patients. We are on target. We are close to having 5,000 patients by the end of the first batch, which will be the next 5,000 patients in the next batch. And the second batch is scheduled to start in November 2024. We will have the results ready in spring 2026. So I want to take a moment for this massive list of site investigators, research staff, my research manager, and all of the staff out in Ottawa in implementation, our biostatistician, and here our KT team is located in the University of Ottawa, Laura. And a big thanks to PSI, which started this journey and also helping me right now, and CHR in the interim, always supporting to make it bigger. And thank you.